Hi everyone, this is the audio review for quiz number 8, which we're going to cover chapters 7 and chapter 19. So let's start with 19, that's the palliative and hospice care chapter. Big thing here is to remember, there are different types of loss and grief. So remember when we talk about loss, there's various types. So loss and change in self-image, developmental changes, loss of possessions, loss of significant others. Grief, we need to kind of realize what that is. It is, in terms of grief, it's important that nurses provide the environment, the outlet for patients to express their emotions, because that's all a part of grief, expressing. And so we need to know that there are different types of grief. Normal, healthy grieving is what we call uncomplicated grief. Okay, it's a very healthy response, and it is designed to help a person accept the reality of the death or the loss. Okay, then you have complicated grief, or it's often referred to as dysfunctional. So this is grieving that is very prolonged, unresolved, and disruptive to one's life. Okay, and usually you have to remember that complicated loss or grief can be associated with a real or a perceived loss. So it's really important. And one of the things that makes somebody more at risk for complicated grief is that they may have a prior experience that is unresolved, or even a prior experience where we're not able to express their grief. It was blocked in some way. And so what you have to remember, these feelings and behaviors are very exaggerated and really disrupt one's routine lifestyle. Disenfranchised, remember that is when somebody's relationship is not acknowledged socially, and so they're not allowed to grieve. And we have to remember disenfranchised might be others are not aware, or it may be that their relationship is not recognized. Okay. And then we have anticipatory grief. Now, this is grief that is before the death actually occurs, okay? When the reality of that death is inevitably known, this is usually when this starts, okay? And it's related to that anticipated death, impending loss or death. And so we have to remember patients experience it as well as family. We talked about the grieving process, lots of influences. You need to be aware of that, cultural, religious, and the age of the person as well. But I want to kind of focus in on the different stages of loss. When we talk about Kubler-Ross, remember the stage is denial. This is the refusal to acknowledge that they have a terminal illness. And so they will often use denial as a defense mechanism. Okay. Then comes anger. This is where they become very upset, very angry with themselves and or others. Okay, and we have to remember, oftentimes that anger is directed at healthcare providers, significant others. But you have to remember they're really not angry at them. Okay, it's kind of that step. Then this is where they go to bargaining. They realize that they're going, they have a terminal illness, and they're trying to buy time. And usually it's a kind of that internal dialogue with a higher power, then they see this as a punishment, for something that they did in the past. And so they try to negotiate more time, okay? And then you have depression. This is where they kind of regress, they get really sad, have regrets, fears, okay? And this is where it's really important to get that patient to review their life, okay? And to learn to kind of get meaning from that and feel like they've accomplished something. And this stage is where they start to begin to accept the reality of their impending death. Individuals' final stage is acceptance. This is they become somewhat emotionally detached, more objective. They come to acknowledging that the loss is going to be inevitable, And then oftentimes this is where they will start making plans. Okay. Let's move on to the next topic. Awareness of illness is really important to understand. Strauss and Glasser's stages of awareness is really important. This is the awareness of the person, the dying person, and the family are in terms of the terminal illness. So remember, closed awareness is family and patient know or are aware that the patient's ill, but they really don't have the awareness that it is there's an impending death. Okay, that's closed awareness. Mutual pretense is patients and family members and care and healthcare providers know the terminal diagnosis, but nobody talks about it. It's not talked about openly. Then we get to the final one, open awareness. Patient and others really discuss the impending death. And this gets to be really important to understand where they are to kind of really be how you can approach it. Okay. Let's move on to palliative care, the concept of palliative care. Remember, palliative care is reshifting the focus from a cure to allowing a natural death in a pain and symptom-controlled environment. Remember, all the interventions are not intended to cure. They're just more intended to manage and make them comfortable and allow that natural death to occur. Big thing here is, remember, it's a supportive team to allow a natural death. Palliative care, remember, 1 year. Usually they have a terminal diagnosis, expected to live about 1 year. They can go to palliative. Remember, difference is hospice. This is really more nearer into life. They have to have at least no more than 6 months to live. That's kind of the main criteria for that. Okay. Let's move on to some legal and ethical issues. Organ donation. We have to remember anybody who's legally competent is able to make organ donations, and so they can do part or whole. So a lot of times it's often done before the decision to donate is before death, but it can also be done after death by family members as well. Big thing here is to remember as nurses, if a family member or the patient wants to donate their organs, we need to notify the physician immediately so they can start doing preparation, to keep those organs viable. There are oftentimes certain things they have to do to make sure that happens. Next thing we're going to move on is, cardiopulmonary resuscitation, CPR. We need to realize, that there are different types of CPRs in terms of patient choices. And so we need to be aware of what those different options are. There are a whole variety. We're just going to cover some. Remember, somebody's a full code. We refer to that. That's kind of what you'll hear in the report. We're going to do everything possible. So CPR, emergency medicine, mechanical ventilation, medication. Okay, we refer to that as full code. Lots of variations of this. You may have somebody who said they only want certain things. So an example would be a chem code. That would be, during resuscitation efforts, heart stops, stop breathing. The only thing that they would do is medications, okay, in terms of heroic measures. There's other variations of that. No chest compression, so that would be everything but chest compressions. So that would be your ventilation, that would be your medication, defibrillation, and so on. If somebody doesn't want any heroic measures, we call it, so do not resuscitate, DNR, or a no code. This is not, we're not going to do anything evasive in terms of heroic measures. We need to kind of understand, advance directives. Remember, these are written documents that state the patient's wishes regarding medical care. It has lots of provisions in it. It includes specific details of when to withhold or withdraw treatment. And the other piece that has on it is it actually, you can designate a person to speak on your behalf for your medical decisions if you're not able to. There are two terms for this. One, we call it a durable power of attorney or a medical power of attorney. Okay. Now remember, this does not go into effect until the physician documents that the the person is no longer able to make decisions for themselves. When that happens, that durable power of attorney or the medical power of attorney now can step in and make decisions. So remember, this does not take place until that patient is not able to make their own decisions. Talk about the process of dying, the clinical signs of impending death. Remember, hearing is usually the last thing to go. So this is where we really emphasize, even when a patient's comatose, the family talk to them. It can be very, very, very reassuring psychologically. Okay. So remember, hearing is usually the last go. And so we really emphasize that, tell the family, keep talking to him. He can hear you. This is usually hearing is the last thing to go. Okay. And so we have to kind of realize, things that occur as a part of the dying process as well. Other things, touch decreases, sense of touch sensation, decreased pain. They tend to lose their taste. Same with smell. They're closely tied together. You'll start seeing blurry vision. They're usually kind of getting glassy-eyed or glazy-eyed. They'll actually start blinking less. Okay? And oftentimes their eyelids will remain half open. Okay? We'll start to see that modeling in the skin, which is kind of a multicolor, pink, bluish, purplish looking. It looks very distinct when you see it. And that has to do with cold and clammy skin. Now, this is the big thing. Respirations is one that's often very distressing for family. They're usually going to have deep and rapid breathing eventually with periods of apnea. We call that the Cheyne-Stokes respiration. Deep and fast with pauses. Then they become really irregular, really start to slow down to what we call terminal gas. We often call that guppy breathing. Okay. And then we'll often hear rattly, noisy tachypnea, fast breathing. And it's very, very common. And so remember, this is built up as secretion. They're actually not having any physical distress related to this. That's usually the big distressing thing that we often see. Remember when we talk about the dying process, that once the actual death is occurring, usually what we will see is respirations will stop first, and then a couple of minutes later, the heart will stop. Okay, and that's kind of how that generally works. So oftentimes this is the thing we can tell them. You know what? We're gonna see them stop breathing first, and then, usually the heart follows within a few minutes. Okay. Dying process, we need to talk about the physical changes that occur after death. Remember rigor mortis. This is where the body stiffens. This happens about 2 to 4 hours, within 2 to 4 hours. And this is all related to chemical changes, which does not allow the muscles to relax. Usually this fully develops about 6 to 12, and then it disappears about 3 days or 36 hours after death. Alta mortis, this is related to temperature. The body begins cooling. Pretty much as soon as the person passes, but you're going to eventually slowly get to the temperature of the environment. Usually that takes about 24 hours. The big thing here, as the temperature changes in the body, the skin starts to kind of lose its stretchiness, its elasticity, and so the skin becomes much more fragile. Liver mortis. That is the breakdown of red blood cells, and often what it looks like, starts looking like they're starting to get bruised, bruising looking. And so remember, liver mortis is going to be evident in dependent parts of the body. So depending on how they're laying, okay. Oftentimes we'll see it kind of in the buttocks, in the back, and the lower parts of the body. Okay, so remember that. So rigor mortis, alta mortis, and liver mortis. Nursing care, at end of life, gets to be really important. Remember, it is a focused assessment. Very abbreviated. All we want to do is detect changes in terms of the terminal illness and their progression towards passing. Okay. We really want to make sure we don't do unnecessary repeated assessments just for the sake of. Generally, most policies and facilities or agencies is usually about every 8 hours is what you would do to maintain the guidelines. Okay, and so that's kind of a key thing that we want to watch out for. Remember, we're looking at neurostatus, ability to communicate, vital signs, temperature, respiratory status, and so on. Okay, so when we talk about interventions for nursing care, remember, we're trying to make them comfortable. So number one thing is managing any discomfort that may occur and pain. So remember, we know they're going to have pain at the end of life. So big thing here is we want to give them around-the-clock scheduled pain medications, not make them have to request it. So we're trying to avoid pain. We are not worried about addiction and so on because they're at the end of life. Okay? So remember, pain is a priority, and we usually will give that pain around the clock. Fear and anxiety is a big piece, so that's really important. Big thing here, is fear of pain, fear of not being able to breathe, fear of loneliness and abandonment. So these are things we need to really kind of help emphasize. And remember, one of the things we can do is simply just being there, listening, and touch. That can provide a lot of relief in anxiety and fear. Remember we talked about preparation of the body, after death. Remember the positioning you want to put them in is supine, with the arms on the side, or it could be across the abdomen. Okay, that's really important. Okay, and when we talk about positioning, and remember, depending on whether they need to have an autopsy or not, everything is removed if there's no autopsy. Usually, your charge nurse will let you know if there's an issue in terms of where an autopsy might be needed. Okay. Remember, replace identification and so on. Okay. Care, we have to take cultural and religious considerations into effect. So, people of Greek descent, their cultural tradition is that the body be cleansed or washed by a relative or an older woman. So if we know we have somebody who's Greek, we need to find out if that is their wishes so we can set that up. Roman Catholics, remember, they should not be shrouded until they've received sacrament. Okay. Orthodox Jew, the big thing here is to remember the patient never want the person to be alone. Okay, and so that's really, really important. And if a person is dying, they should not be left alone. So it's really important that if it's Orthodox Jewish, if there is nobody there with them, we want to make sure we notify family if death is imminent. Okay? And so that's really important. Remember, we don't leave them alone. Once they pass, we don't do anything with them for about 30 minutes. And they are never left alone from death until they're buried, okay? It's really important, and they must be buried within 24 hours of passing away. And somebody who must be a designated Orthodox Jewish person or a Jewish burial service is the only one that can provide care for that body. Okay, so it's really important that they are not left alone and they don't die alone. That's chapter 19. So let's go back to chapter 17. That's the cancer chapter. Remember, when we talk about cancers, it's really important. It's the second leading cause of death, and 1 in 3 Americans will develop some kind of cancer during their lifetime. So remember, the most commonly diagnosed cancers or new cases in men is prostate cancer, and for women it's breast cancer, and then it follows with lung cancers for both. Okay, that's the second most leading diagnosis. We also need to kind of remember that lung cancer is the number 1 cause of death in men and women. When we talk about prostate, it's the number 1 diagnosis, but it's the 3rd leading cause of death. And for women, breast cancer is the second leading cause of death in terms of cancers. So when we talk about cancer, we need to talk about cells, the difference between normal cells and malignant cells, as well as benign cells. Okay, so it's really important to know those differences. So, characteristics of normal cells: very distinct appearance, very typical of the tissue where its origin. If it's a liver cell, it looks like a liver cell. If it's a skin cell, it looks like a skin cell, and so on. And it's able to perform its function once it's matured, and it's able to secrete substances that keep the cells nicely held together, keeping the brothers and sisters nicely attached and connected. Okay. We're able to identify them. We can look at them and really tell. Okay. And cell division occurs, but will be inhibited or stopped when there's not enough room for cells to multiply, or there's not enough nutrients. Okay. And then the other piece of this is that they will stay in their place of origin. They don't travel. The only exception is, blood cells, your RBCs and all that. Okay. They're the only ones that do travel, but everything else should stay in where they were originated. Okay. So remember, benign cells versus malignant cells. Benign cells, the cells themselves are not harmless, they're not cancerous, but we worry about, they don't spread, but what we do worry about them is they grow in causing pressure or causing obstruction. And that's usually surgical removal is recommended for benign tumors because of that risk. Okay, and it can cause damage to neighboring structures and organs. Malignant tumors, remember, think about normal cells versus malignant. Malignant or cancerous cells look different from normal cells, change in appearance. They're not able to perform the function. They're kind of just a cell there, not really doing anything. Sometimes they may assume function of other cells, not where they're located, okay? And then that causes issues. They will have abnormal proteins on the surface. We call them tumor markers, and that's often one of the laboratory tests we may do for identification. And remember, growth is random and out of control, uncontrolled. Doesn't matter if there's no room or not enough nutrients. It's just going to multiply like crazy because of it. And it has the ability to travel or migrate to other organs, when we call, that's regional invasion and metastasis. Okay? We talked about malignant transformation. Remember, there are a lot of factors that contribute to malignant transformation. That includes age, diet, hormones, and chronic irritation, as well as exposure to carcinogens, anything that can cause change in DNA of a normal cell. Okay, so remember, there are four steps in terms of malignant transformation. Remember, introduction, that's the exposure to the carcinogen. This causes irreversible changes to the DNA, so just an initial. So the cells will start to appear somewhat abnormal, not super obvious, but we'll start to see it. Then promotion is the next step. They have enough exposure to this carcinogen, and so now we start to get, or to an agent, a promoter, and it encourages or enhances growth. So we're promotion promotes growth. Okay. And this is kind of before the major increase in growth. Okay. Then you have your progression. So that's really fast, rapid growth. They get really evasive in terms of growing and spreading, and we start to see obvious alterations in the appearance of these cells and the biochemical activity. So this is where we really see the tumor development, and it's a very obvious mutation, and so they're not identical to the surrounding normal tissue. Okay. Then you have metastasis. That is basically it breaks off and travels, but part of this is that blood vessels develop, so it gets its own blood flow. It produces enzyme They start to break down the normal cells that kind of keep attached together, and then the tumor starts to penetrate. Okay. And so these cells are transformed and can relocate or travel or migrate. Okay? And that's kind of the key thing we need to know. So remember, steps: initiation, promotion, progression, and metastasis. We talked about a couple of ways that tumors are classified. Remember, it can be done anatomically, or it can be done by what we call a staging system. The basic one that we most hear is considered a general classification. It has stage 1, 2, 3, and 4. Remember, a stage 1 is malignant cells. Cancer cells are confined to the tissue of origin, and it hasn't invaded, it hasn't traveled anywhere. Okay, so it's in the same spot, very kind of tightly packed. Okay, then you have your stage 2. It has a little bit of spread, it's more localized. And oftentimes it will involve traveling to the lymph nodes. Okay. Then you have stage 3. This is tumors larger. It's spread from the site of origin to nearby tissue. So it's not really metastasis, it's just spreading. And then regional lymph nodes are usually most commonly involved. Then you've got your stage 4. The cancer has metastasized to distant parts of the body. And we often refer to this as advanced stage of cancer. Okay, so make sure you know those different stages. Okay, we talk a lot, another staging system which is more specific, and it's often used to monitor progress, especially after treatment. So remember, it is the T and M system. So remember, T is for tumor, N is for lymph nodes or nodes, and then M is for metastasis. So remember, 0, when we say, they're given a number for each one of these letters. So your T could be a 0 to 4. So remember, 4 being no signs of a tumor after treatment, all the way to T4, which is large. It's actually very large, and it extends very much into the surrounding tissue. Then you have your N for node, or your regional lymph node. Remember, N0 means none of the lymph nodes are involved in the cancer. And you get to N3, it's extensive involvement of the lymph nodes. So remember, N1, minimal, N2 is increased, N3 is extensive. And then the M in the system, in this classification system, is related to, metastasis, distant metastasis. So M0 means no metastasis versus M1 means distant metastasis is present. Okay. So these are classification systems we will often see, and you will see this. It'll be like a T through T, T2 with an M2, M0, and you have to be able to be able to understand what that means. When we talk about cancers, the big thing here is risk factors. A lot of genetic environmental pieces we need to be aware of it. Carcinogens, so think about high-fat diet, smoking, alcohol, those are all considered carcinogens. We also need to realize that obesity plays a piece in this, for certain types of cancers. It's really important. Drugs also as well, androgenic steroids, anti-neoplastic drugs. These are all can increase the risk for cancers. Also remember, there are familial cancers. Remember, familial cancers, there's not really a specifically genetic component, but there seems to run more likely in families. We see it. Then you have hereditary, and that's where there's a genetic link to the cancer that runs in families, and that's how they track it oftentimes. Genetic counseling is usually a part of that. When we talk about teaching patients, when we talk about these risk factors, we need to one of the big things that really works really well to help them remember or help identify problems that might indicate cancer developing, especially the more common one. We call it the 7 warning signs using the CAUTION acronym. Okay, and so each letter kind of spells out something as a reminder. So C, change in bowel or bladder habits. A is a sore that won't heal. U stands for unusual bleeding or discharge. T stands for thickening or lump in the breast or elsewhere. I stands for indigestion or difficulty swallowing. And O stands for obvious change in wart or mold. And N stands for a nagging cough or coarseness. So this is something we can really teach patients to do, okay, to really help reduce or help with early detection. Mainly, if they start to have these symptoms, they should report it immediately. We talked about diagnosis of cancer. There's lots of ways you can do diagnosing. You know, of course, it starts off with health history and physical exam. The big thing here is if somebody's at high risk, usually they're screened, okay? That's kind of the key thing. But remember, it could be imaging. You know, we talked about mammograms. It could be endoscopies, which is taking a scope, like a colonoscopy, taking a look at a CT. That's using imaging, okay, or endoscopic procedure. But lab tests can be done too. There are lots of different types of lab tests that are very specific to cancer. We talked about tumor markers, right? And so those tumor marker tests, they're not super specific. They often can indicate several different types of cancers, but they're often a part of helping with diagnosis as well as monitoring the effectiveness of treatment. Some examples is the CEA, your carcinoembryonic antigen, your AFP, that is your alpha-fetoprotein. There's a bunch of the CAs, I call them. So CA125, CA19-9, your CA15-3, prostate specific antigen that's used for prostate, PSA. There are several. Big thing here is to remember, it's often it's not necessarily definitive in diagnosis, but it can help indicate, because each of these different proteins can indicate certain specific cancer. Not one specific one generally, but it helps limit it, and so they can figure out where it's at. And the backside of this, they will often check these tests to see how the cancer treatment is working, if it's effective. So oftentimes if these protein markers are still elevated while after they're getting chemotherapy or during chemotherapy, especially if it's a long-term chemotherapy, they will have to reevaluate what their approach in terms of treatment. Remember, surgeries is often used if it's detected early. Removal is kind of the key thing. We usually say surgeries is curative in terms of cancers, particularly if it's detected early and they're slow growing, confined to one area, and has not metastasized or invaded any vital body structures. Okay. So that's surgery. So the other thing is radiotherapy or your radiation. Remember, this is using ionized radiation. This actually is great for cancers because malignant cells are much more sensitive to radiation. So remember, there are two ways radiation can affect these cells. So first one is immediate. The immediate effect of radiation is that it actually destroys the cell membrane and causes cell death. Okay. The second way that radiation can affect these cells is, we've referred to it as delayed response, but it's not killing the cell immediately. What it's doing is altering the DNA, causing the cell's ability to reproduce, to limit the ability or impair the ability of it to reproduce. And so eventually it will die off. Okay? So it can't multiply and spread. Okay? When we talk about radiation therapy, we need to kind of talk about side effects. Remember, bone marrow suppression is a big piece of this. So we're concerned about low red blood cells, which could be anemia. We're worried about bleeding, and that has to do with decreased production of platelets. And then we're worried about risk for infection because of decreased production of white blood cell. But remember, side effects in general, we will not see them with radiation or radiotherapy until at least 1 week after the start of treatment. Okay? That's really important to know. Chemotherapy, we talked about that. Administration of anti-neoplastic agents. It could be multiple routes, so oral, intramuscular, intravenous, intercavity, and interthecal. Okay, so kind of remember that. But remember the side effects are very much the same, that bone marrow suppression, and we worry about that with chemotherapy. We need to kind of talk about end of life when we talk about cancer, terminal illnesses. So remember, that, oftentimes when it's found that the cancer is they're not able to treat the cancer or remove the cancer, they're usually going to be put on hospice. You remember hospice, the basic premise of hospice is controlling the symptoms for comfort, especially pain, so that they can have a comfortable death. Okay. Remember, when we talk about pain management, around the clock. We don't care about addiction or anything like that. And you have to remember, hospice also provides that bereavement care after the person passes, to family and etc. Last thing we're going to talk about is oncological emergencies. There's lots of different ones that are very common as a result of the cancer or the treatment in itself. The chemotherapy, radiation therapy, and so on. So, we need to know these. So remember hypercalcemia, that is elevated calcium levels. So remember, with this one, we will see fatigue, confusion, weakness, constipation. We're going to often see increased in urination, so polyuria. We will often see hypertension, tachycardia as a result of it. And then, of course, remember muscle weakness, so poor muscle tone. Remember, if this is not addressed, we can have possible renal failure, coma, and it can actually cause cardiac dysarrhythmia, so heart rhythm problems, and can lead to death. Okay. Another one that we often see with this is syndrome of inappropriate antidiuretic hormone, or ADH. Remember, this is the one where they're not the mechanism to help get rid of water is partly lost. So they start retaining fluid. So we refer to that as water intoxication. And so as a result, they get what we call delusional hyponatremia. And that has to do with basically they're retaining water, and so their sodium levels are being diluted. So they're getting lower and lower when we talk about comparing the amount of water, because you're keeping a lot of water. So what we usually see with this one is nausea and vomiting, anorexia, weakness. Usually when this first comes on, we'll start to see lethargy, followed by confusion, often psychosis, and then it could develop seizures, coma, and then could lead to death. Remember, low sodium is really a dangerous thing. Okay. Disseminated endovascular coagulopathy is another oncological emergency we need to kind of know. This is a clotting process that's exaggerated. And what that means is the body, for some reason, is triggering clotting to occur exaggerated, and to the point so fast and rapid that it uses up all of its clotting factors, uses up all the platelets. Okay. And so when it runs out, the bone marrow can't keep up. Okay. And that's kind of the big thing to remember. And so what we end up seeing, if this is occurring, is, kind of the early signs of bleeding, indicators of bleeding. So we will often see petechiae, ecchymosis for no explained reason. They didn't bump it or hit anything. Prolonged bleeding for any needle sticks or punctures. Towards the end, what we start to see is, late stages, we're going to see, tachycardia, dyspnea. Usually we're going to see some gastrointestinal bleeding, and then often heart failure and then shock. Then you have this next one, we have superior vena cava syndrome. This has to do with superior vena cava in terms of what we will see is edema kind of from the chest up all the way up, kind of up to kind of above the mouth, basically, to the nose. And this is edema. We'll often see cyanosis, very profound, more noticeable veins on the chest and arms is notable. And remember, the arms is included in that edema, okay? So it has a very classic presentation. And we're going to really see distended neck veins. So this, remember, things are swelling up. So dyspnea, they're going to have a cough, tachycardia, they're going to become oftentimes hypoxic. One of the big things we worry about is increased intracranial pressure. That's kind of the end result if this doesn't get managed. Okay? Spinal cord compression, this has to do with tumor in those epidural spaces in between the vertebrae. And so what this usually causes is extreme pain, weakness, alterations in sensation, particularly in the arms and legs, and we will often see impairment in bladder or bowel function. Okay. That concludes the review. Let me know if there's any questions.